I think 90% of my job, 95% of my job is done. So I just made and changed some slides because I felt looking at the cases would help us to share what Rajesh has already, effectively laid the basement. So it's a tough job for me now. What I have done is I have picked up some cases which possibly we see in as our referral cases and trying to get some clinical details and see what we derive from a test which is just asked simply thinking from the perspective of ANCA or ANA. So this theory I will not be touching on. Yeah. So we see young female presented with decreased urinary output, fever on and off, weight loss, loss of appetite. Investigations show hemoglobin on the lower side, mild. BUN creat is high. If you look at the uric acid, yes. Phosphorus, cholesterol, electrolytes normal. Urine shows albumin 2+. Look at pus cells and blood. Chest X-ray and AFB is normal. So if you look at the history, it appears more like a renal history to me, and you don't know about her blood pressure, but the moment you see a proteinuria, today we being a diabetic and a blood pressure capital, we think, okay, are we looking at that? But this was not referred as a case of autoimmune. So how, as remember, we are treating patient and not serology. So that concept when we remember and we go back to the clinician, what information you get with a good, this was not asked after talking obviously, ANA, DNA negative. So what is it? Because when we asked what is wrong with the patient, why so much of proteinuria, is the patient having UTI, so obviously those things and constant dialogue with the clinician helps us to make that impact on the clinician, because finally it's the patient. So after talking about ANA, DNA, remember in private practice when you are in an institution, it is still easier, but when you are into a standalone lab telling the clinician, अच्छा try ANA, DNA, वो नेगेटिव आने के बाद आप बोलते हो अभी एंका करो क्योंकि बाकी सब नॉर्मल आ रहा है, एंटीबायोटिक्स के बाद भी प्रोटीनूरिया परसिस्ट कर रहा है, स्पेंडिंग मनी, ओके, आई डोंट नो, that depends on our conviction and our knowledge, how we are able to see what we got. We did IF and I agree, I think we have been debating with ANCA IF that what should be done, and yes, I am glad that 2017 it will really relieve that pain. But I think IF also has helped us in many ways in identifying many other things apart from ANCA. Here we saw C ANCA positive, P ANCA negative. Lot was followed not in my lab, but we got it from one of our referral labs as MPO positive and PR3 weak positive. Obviously GBM comes in that lab, so that was negative. So what do you look at it? Now when the case came to us just as a routine check, renal, kidney, CBC, there are these packages, and we see a urine infection, we talk to the clinician, we get to know patient is not hypertensive, no complaints of UTI, in spite of RBCs present and pus cells and proteinuria. We said, put her on antibiotics, come back, because generally females, they don't even know they are suffering unless you actually diagnose and give it. ANA negative, DNA negative, talking, persisting, getting the clinical inputs, this is where we come. So where are we? Now we are looking at either autoimmune nephropathy, differential diagnosis we will have to, because you are only supposed to give it. Not many clinicians are well, when you have a general practitioner with a GFM and a LCH or a homeopathy kind of a background, giving this is exciting. At the same time, you feel very happy that you are adding this to that. Patient was put, very recent case came to us in March. Patient is actually referred to one of the clinician in Amreli, and now she is on this treatment protocol. These pictures, thanks to Dr. Jariwala, I could take it from him because I have to give those pictures for you all. this is what it shows when you use, as Rajesh suggested, that some of them may give you a substrate, or even this itself is good enough for you to know it is positive. This was a plot which was confirmatory. Obviously, imagine amount of, I'm constantly stressing on money. The reason is private, you have to think about it. But once you are adding that value, here I'm just reinstating what Rajesh said, that we have to look at the end result, that is our patient. And this was the MPO positive, which I requested and they gave me the scanned image. So the theory part we'll miss. I have 7 cases and then you have the workshop. So I think let's look at the cases. Yeah. A second case, 78-year-old female admitted with fever, joint pains, weight loss. Obviously 78 में intentional weight loss नहीं होगा. In our age it will happen. Tingling numbness. So when this complaint comes, our physicians generally look at B12 deficiencies, right, or anemia. Hemoglobin 9.1, okay, weak positive. Though I was not happy, this was not done at our place. These are the records which we have retrieved. When we are talking, we are sitting in the era of autoimmune and workshops, but we still have 50-100 kilometers away from us where we are sitting, where people are still doing semi-qualitative things. So this is how the report was. C3, C4 were normal within the range. ACE was done, BUN, creat if you see 2, PCT, I don't know the reason why it was done, but I thought maybe I can put it, and urine culture showed this particular report. So what we did, because of this particular thing, we said okay, this was not suggested on day 1, obviously sequentially. So because RA was positive, we confirmed it on quantitative. We said this does not guarantee definitely rheumatoid arthritis unless until it's a clinical diagnosis, though the new revised criteria do say that, but it carries 2 points if CCP is positive in the new classification. So CCP, ANA by IF, DNA, and obviously these were coming at a later stage. You can find something very exciting, what we found. DNA positive, it was done by IF, confirmed by ELISA. We don't know why our referee did that by IF, but that's okay. ANA IF, borderline positive, it was fecal plus minus. ANCA, P-ANCA, we saw the slide personally, again thanks to Pratik. We saw that there was a weak positive. It was not a very good fluorescence. I was not convinced about reporting it as positive unless I confirmed with ELISA or a blot. So we did a blot where we saw weak positive C-ANCA. This is something which complemented what I am going to tell you ahead of this. Is anti-CCP positive, strongly positive, around 200. So, recently, when you have more time, you read more, and when you read more, you think about a lot of things, what's wrong with this patient. Because what was niggling to me, which I have not mentioned, is OTPs, the patient's liver enzymes, were constantly, she showed me 3 years reports. All the reports were like 48, 52, never within the normal limits. I don't know why, even the bilirubin was, I don't know, many times we have seen labs do, if the cutoff is 0.8, they, at the value is 0.9, they like to give it 0.8. If the CKMB of the patient comes 25 and the cutoff is 24, they like to give it 23 and repeat it because of the CV or what, I don't know. But I really saw 3 years consecutive reports of AST ALT on the border. So we said, what's the reason? So we told that एक B or C कर लेते हैं, because when you read, you think about it. So we saw a B positive. This was the picture. I said I was not happy with the fluorescence. This was when, I think IF, as Rajesh said, we had one session of infertility up, and ANA can give you immense value when you see other patterns like, beautiful needle-shaped extensions running across. What does that point? He just, I think 4 slides before, he told you exactly. So DNA, I think, not important. We confirm this. If you see PR3 is positive, Do you think it fits? Why? Because peer, on detailed digging of the patient, what we saw was patient had three symptoms which possibly, one which alerted me, and I spoke to one of my gastroenterologists because we were worried that why is it the patient is having loss of appetite, loss of weight, okay, obviously non-alcoholic, tingling numbness, and it was very apparent. She was always telling, mujhe chalne ke time, I feel, if you sit in one position for longer time, how your things get numb. She used to feel it throughout the day. B12 and a lot of other things were done. I also did the thyroid, I didn't mention it because I thought sometimes hypothyroidism will get this but not weight loss. And patient was willing to go extra mile. She said, "आप कुछ भी करो लेकिन मैंने सुना है, you can help us." So we were thinking about this. We were thinking about her OTPTs, okay. Nothing else fitted. But if this is one of the reference which I tracked, and I also spoke to Dr. Samir Parekh, who is one of the leading gastroenterologists, and he did refer. He said, "Aparna, if you say you love autoimmunity, look at this condition. This is we know this condition, isn't it? But I haven't seen any clinician labeling a case of PAN, but these cases are known. 3% of the cases, very rare." Not proved, but I thought of putting this to you all because it's a very, very new case and very exciting case for me, where we went back from the clinical history to diagnose ANA, ANCA, hepatitis B, and she has not seroconverted. I mean, she is a positive carrier patient. So, yeah, exciting case, isn't it? And some of them will have CANCA, and we saw all these things in this patient. Trust me, she is referring a lot of patients to me now. So, I am very happy. I wanted to share. Third case, 45-year-old female, fever, joint pain. Another thing, what we see as a laboratory, I'll say physicians, any patient who comes with joint pain, we had a CME last week, joint pain, and people think it's rheumatoid arthritis. How many of you see that? People write blank RA-ESR instead of writing CCP. Right? Reduced appetite, nausea, vomiting, distension of abdomen. Hemoglobin, you can see platelets are low. Fever है तो डेंगू तो पूछना बनता है. Lepto was also asked. TFT, TB PCR, I don't know why. I am saying that this also should not be done. A blood PCR rather than the focal sample. C3, C4 decreased, okay, and OTPT is high. What do you think? Platelets are low, fever है 20 दिन से, broad idea. Okay, I'll go ahead. Abdominal distension, I read it. Okay. So ascitic fluid tapping. I am not like Rajesh case में हम लोगों ने पढ़ा नहीं था minocycline. All of us forgot to read that. It was a nice case. Ascitic fluid tapping was done. Cytology, chronic inflammatory exudate, ADA normal. This is what, there is a common joke running in the community that anything, I think I always say, okay, whatever happens, Aparna will say do ANA. But actually we prove it, isn't it? We said ANA karo, speckle 2 plus, DNA positive, of course ELISA, ANCA P positive. ANCA blood added, because somehow I felt it possibly not fitting into my imagination of that case. Liver blood was advised. I'll show you the picture if I have that here. SMA. Now where are we? Smooth muscle. Any guesses? ANA positive? Clear now? I'm giving you a hint here. Anyway, मैंने diagnosis भी लिख दिया है. Hepatitis C. So this is not that picture. So I have taken it. This is the picture. If you see MPO positive, liver blood, SLA LP, okay. So AIH with SMA, I am not having the SMA IF picture. It's a basically progressive condition of liver. Actually, there should be one lecture separately for autoimmune hepatitis but I was told that ANA छोड़ के मुझे बाकी के cases touch करने हैं, so I have picked up those cases. It's a wonderful case if you actually look at each clinical symptom, isn't it? It was telling you distension of abdomen, it was giving you OTPTs are high, it was telling you hemoglobin is low, platelets are borderline low, and everybody was thinking around the patient from the infection line like leptos and dengue of the world, whereas it was autoimmune. This theory part we can skip. And yeah, this is my last case. I always like to say thanks to those who see my husband, because I do a lot of experiments. Animals are quiet people, they don't talk. But if you see some symptoms, I always like to use my lens and say, okay, it's autoimmune. So this is a poem of a very VIP client. He says, कुछ भी करो, चेन्नई लेके जाना है, कहीं भी लेके जाना है, आप diagnose करके दो. So then immediately I come into the role, and if the owner is my favorite, I really go back. It's like somebody from the film celebrities. So 8-year-old Pom, that means quite old. The life of the dog is around 12. Owner complained of difficulty of taking her for walks. So sex is female. Okay, so antennas are up. Pom was struggling in her hind legs to walk, difficulty in getting up even for food. That's difficult. Had difficulty, weight loss and fever. Though the ranges are different, okay, but still this falls into anemia. Platelets, the normal range is about 2 lakhs, so this is low platelets. Urine, okay. OTPT, the PT, their PTs are up to 50, so it's border. Creat is definitely high. 0.8 is the normal range up to highest. Blood culture negative, okay. Urine culture because of this was asked. This is what excites me. Priyanka positive. So what we did is, we also did a renal biopsy thanks to my teacher, Dr. Elima Rande. She is from Sion and now she's retired. I did the biopsy. It was a big task for sedating the dog and doing that biopsy. And dog is now responding well. She reported it as glomerulonephritis, possibly amyloid is something which she has said, along with nephritis. The dog is on dialysis and steroids. So coming back to this, so what excites me is then we can offer this help also. It's not validated, but if we think from the clinical history, I want to just reinstate on the point which Rajesh ended with, that if we look at the patient as our final destination and we go back and cut the clinical history step by step, I think 4 cases, we have hundreds of such cases, but 4 cases, what are they proving to us? That if you are good in your technique, your basics, but if you pick up the phone and talk and get the inputs, you can make wonders. With that, I would like to end. Thank you.